cardiovascular system. And the heart is a thick-walled, very muscular, hollow four-chambered organ. It is housed in a sac with a visceral and a parietal layer, very similar to the lungs. And there's three main layers of the heart: the epicarium, the myocardium, and the endocardium. So the myocardium is that big muscular portion of the heart. You can see here in this picture, there's the outside. Here are the coronary arteries, and it's the coronary arteries that take nice oxygenated blood from the aorta and actually supply blood supply and oxygen to the myocardium. So 3 different really important topics, and if you go to this link at Mayo Clinic Heart Failure Information, there's a lot more information on this. Also in your book, they talk about pericarditis, and pericarditis is an inflammation of that pericardial sac, and that can be due to infection, lots of different problems. It could also happen with trauma. Myocarditis is when there is an infection or an inflammation of the myocardial sac itself, and then the muscle wall. And then cardiomyopathy is from an overworked ventricle or ventricular chambers. And that's generally as a result of, for some reason, the heart having to work harder and pumping too hard and having high blood pressure, trying to overcome the resistance in the vessels. And there's a multitude of reasons for that. So as I said, please go and look at some extra research on those, because those terms will be very common to you in your practice. So different heart chambers and valves. We know there's 2 atria, and they are kind of they're a lower pressure chamber, and they provide an area of holding and an area of, like, say, take for example, on the right atria is where the deoxygenated blood comes into the heart. The left atria is where the oxygenated blood returns to the heart to continue on its way to get pumped to the rest of the body. So we can see here that the bottom part of our body from the systemic, and systemic just means our entire body itself minus the pulmonary system, will get, after the tissues in the systemic circulation take up the oxygen, then it'll get the blood itself will get transported back to the heart via the inferior, or in the upper part of the body, the superior vena cava. It'll go into the right atria. It'll get pumped through this tricuspid valve. It'll move down into the right ventricle. Then it'll get pumped through the pulmonary valve. It'll go through the pulmonary trunk to the pulmonary arteries. You can see here the pulmonary arteries will go then to the lungs, get oxygenated, come back via the pulmonary veins into the left atria, through the mitral valve, which is the really strong valve that sometimes, due to the high pressure in the left side of the heart, can wear out, down into the left ventricle. And if you can notice here, it's the myocardium of the left ventricle is that really strong, because the left ventricle is the main workhorse of the heart. It has to pump a lot of blood, so therefore it's a very high pressure system to pump the blood through the aortic valve, through the aorta, all the way to the rest of the body. So the left ventricle has the highest pressure because it has to work against pumping blood through the rest of the systemic circulation, whereas the right side only pumps the blood to the pulmonary system, and so it's at a lower pressure. So then we have the blood that gets oxygenated and provides flow to the rest of the body. Okay, and so here we go through the left common carotid, the left internal jugular vein brings it back. We go from the brachiocephalic on the right side to the right common carotid. And then the right internal jugular vein brings it back. It's deoxygenated after it's been taken up. Okay, so the aorta just branches down and continues to branch down into smaller and smaller branches. So for us of interest, of course, we will be looking at the radial blood supply, the brachial blood supply, because that's where we'll be taking arterial blood samples. So the arterial side is that oxygenated blood. It's a higher pressure system. So it's also, is oxygenated. It's an aerobic system. So it's a better snapshot of what the body's actually doing in terms of pH and PaCO2. Okay, so here's just the arterial side versus the venous side, whereas this is the main area taking blood to the heart, and then from the heart itself, it dumps back into these veins to meet up with the deoxygenated blood supply. So here we have the coronary supply, and once again, the coronaries are very important because they supply oxygenated blood to the myocardium. So of interest, of course, is the very common myocardial infarction. So what happens during myocardial infarction, and the common term for this is a heart attack, and that is where your coronaries get blocked. And so a portion of the myocardium, the heart muscle, gets deprived of oxygen, and so we call this a heart attack. We're going to learn, this is kind of a funny joke, when we learn about electrocardiograph, when we don't have a smooth, small QRS complex, if that gets widened, that's how we know there's been damage to the myocardial muscle. So this will be funnier later when we do EKGs. So here's another good picture on a chest x-ray, and this just kind of outlines the normal anatomy of the heart. So here we can see our aortic arch, our superior vena cava. We should be able to see our pulmonary trunk right here on the side, our left ventricle, our right ventricle. So we're going to continue talking more about imaging throughout the program. But one thing to note, the heart should never be more than 50% of the image. So, and that's the whole mediastinal cavity. So this is a good picture of a heart. If it were really big, meaning greater than 50% of this whole mediastinal cavity, then that's probably an indicator of cardiomyopathy or congestive heart failure leading to cardiomyopathy. Okay, this picture is atherosclerosis. So this is where there's a plaque buildup in our arteries. Okay, we can see that here. And what that exactly does is that decreases the radius in our blood vessels. So it provides a lot of extra resistance. Just as comparing that to the respiratory system, how mucus or some sort of blockage in the airways would cause extra resistance. So if you see you have to get blood flow through these arteries, if it's got this extra atherosclerosis or plaque blocking it, the heart is going to have to pump a lot harder to create that pressure gradient to move the blood from one area to the other. And it's going to have to use a lot of extra pressure. So this is where hypertension or high blood pressure would really take place due to this atherosclerosis. Okay, so we have more aortic anatomy here. Here we have the aortic arch. Coming from the right side, it'll start with what's called just the brachiocephalic trunk and go to the right common carotid and right subclavian, or on the left side, it goes right to the left common carotid and the left subclavian. Then it goes down here, all the way down. Here is our good femoral arteries. Actually, about right there is our femoral artery. So the closer to the heart we can say, it's more central. As we move on, it becomes more peripheral as we go down. So, as I said before, we'll get pretty familiar with our brachial and our radial pulses, because this is a great area for taking an arterial blood gas. As you move away from the heart and go more peripheral, the arteries are not as strong. I mean, the pulse can be harder to find. And when patients have low perfusion, such as in the case when they're in shock, the more peripheral arteries tend to constrict more to conserve the blood for the major organs in the body. And so if we are having a patient that's really sick due to shock or any type of low perfusion status, our radial artery will be harder to get a blood sample from. So we would have to move up to a more central artery, such as our brachial, or even our femoral artery. So arteries and veins don't always mean oxygenated and deoxygenated. Arteries themselves mean they move away from the heart. Arterioles are those smaller arteries that are surrounded by smooth muscle. So just as we had bronchioles in our respiratory system, that's the portion that are surrounded by smooth muscles. And due to the autonomic nervous system, if there's extra sympathetic impulses, it will actually cause vasoconstriction and bronchodilation. And that is just to control the flow of blood to certain areas of the body. And then when we're talking about that from the respiratory system, different airflow down into the lungs. So take, for example, if I scare you really quickly and your sympathetic nervous system gets activated, that is your flight, fight, or freeze response. Epinephrine, in other words, adrenaline, that's in the neurotransmitter that would get released. And then the smooth muscles in our arterioles would constrict to keep the blood flow shunted to our main organs, and then also to really spike up that blood pressure. And then in our respiratory system, our bronchioles would be opposite. We would see bronchodilation or relaxation, so that we make sure that we get nice flow of oxygen and lots of airflow to our lungs themselves. So we move away from the heart in our arteries. And then we have our arterioles. Then we have our capillary network, both in our tissues as well as right there in our alveolar capillary membrane. So this is where gas exchange takes place. If it's between the blood and air, it's called external respiration, and that's there at the alveolar capillary membrane. If it's between our blood and tissues, it's called internal respiration. So then we move from our capillaries where gas exchange takes place. Then those will empty into our smaller venules all the way up into our veins. And the veins are a low pressure system. They're just called capacitants, meaning they just hold blood. And then they take the blood back to the heart. So here we can just see more vascular anatomy. So here is an artery. Here is an arteriole. Here's the capillary bed, which will empty into a venule, and then the vein itself. So blood flow through the heart, it's very important that you understand the blood flow to the heart, because we'll deal with a lot of scenarios, especially next year when we start talking about congenital heart defects. And how, as a respiratory therapist, we have to understand how the blood flows to see what needs to be oxygenated and sometimes what doesn't need to be oxygenated. So once again, We have deoxygenated blood, so the tissues have already taken the portion that they need to do their processes. Blood empties from the bottom portion of the body through the inferior vena cava to the upper portion of our body through the superior vena cava. That blood comes into the right atrium. It goes through the AV valve, and on the right side, that's called the tricuspid valve. It goes down into the right ventricle. Then it goes through the pulmonary valve. Another word for the pulmonary valve is a semilunar valve. It goes to the pulmonary artery to the lungs, where it gets oxygenated with blood. It comes back from the lungs through the pulmonary veins into the left atrium. It goes through that really strong mitral valve down into the high pressure left ventricle. Then it goes through the aortic valve, and it goes through the aorta to get pumped to the rest of the body. The pulmonary artery is the only artery in our body that's deoxygenated. So once again, artery just means away from the heart. So the pulmonary artery is the only deoxygenated artery in our whole body. And that's because it's moving away from the heart to travel to the lungs, in which it will pick up its oxygen and release the carbon dioxide. And then the pulmonary vein is the only oxygenated vein in our bodies.